Well, good morning. Welcome to another in my Vignette series. Today I'm going to be talking about the Miller family. And this is going to be a narcissistic dad pattern with a normal range targeted mom and with two children just under adolescence, a 13-year-old daughter and a 11-year-old son. And in this vignette, I'm going to be focused mostly on the involvement of the other professionals. So for the family dynamic, you can turn to other videos because it's a pattern. And so we're in the narcissistic dad pattern. But it's also a pattern regarding the involvement of other professionals. So that's what I'm going to be talking about today. So here we have just the demographic information about the Millers. We have an allied father, narcissistic dad pattern, and a targeted parent mother, two children, 13-year-old, that should be daughter, and 11-year-old son, and the involvement of the other professionals. So here we have the genogram for that. Always recommend a genogram. And so the family has been together for quite a while, 16 years, 2-year separation on this, and targeted parent, targeted mom, allied dad. So one of the features about this pathology is that it recruits allies and it recruits them into the protective other role. And these allies believe the shared delusion is true because of their professional incompetence with narcissistic borderline and dark personality manipulation. And so there's two aspects of that. One is that protective other role. So if you understand the transgenerational transmission of trauma, that there's a trauma pattern in the attachment networks of the allied parent that's in the pattern of abusive parent, victimized child, protective parent. And in the current situation, the reality is just parent, child, parent. But because of the unresolved trauma, the allied parent is adding those adjectives. So instead of just parent, child, parent, it's now abusive parent, protective, or victimized child, protective parent. The targeted parent is the abusive one. The child is a victimized child. And it's very important for the allied parent to fill that role as a protective parent. That's a little bit of a corrective change in their trauma that's trying to work itself through. And so that's a very distinctive feature of this pathology, is that need to be in that protective parent role. And if you're a protective parent, you need to have a victimized child. And so they create the victimization of the child, get the child to believe they're being victimized. As soon as the child says, I'm being victimized, now they can come in the protective parent role. And so they will be very resistant to taking that child out of the victimized child role, very distinctive. But what we're talking about now is that the surrounding mental health professionals get captivated on their own, what's called countertransference, their own unresolved trauma pattern in their brain that's got an abusive parent, victimized child, protective parent. And so when they get presented with that narrative of a victimized child and a protective parent and the whole pattern, they join on in the protective other role. So it's like they join the allied parent and they're both now protecting the supposedly a victimized child against the abusive parent, but none of that's true. Okay, it's all a trauma reenactment. That's a delusion. And that's why I say if the mental health professional believes the shared delusion, they become part of the shared delusion. They're getting captured on their own trauma reenactment path, and they're creating the shared delusion. They're communicating to the child that their delusional fears and delusional beliefs are true when they're in fact a symptom of pathology. And so that's the fundamental feature about understanding how these mental health people get allied, is they're getting captivated on that protective other role. And they're particularly vulnerable to that because we're mental health people. We come in to help people, and oh my goodness, especially, victimized children and abused children. So we're already biased in that favor of that helping, to not be skeptical. And then if you get their own countertransference stuff, they just blend right into it. Particularly the individual therapists are particularly vulnerable to this, but any of them, legal professionals, can get caught because they're not aware of the balance. And so if they've got any of the counter transfer and stuff, boom, they immediately go into that protective other role, which is often what brings them to the family courts. They want to do that. So let's start by talking about a common role, the GAL. And so again, this role, when it gets assigned, in my view, we have a totally okay guardian, and that would be the mother. She's a normal range parent. She can be the guardian. We don't need another guardian. We just need to diagnose which parent's abusing the child, recognize it's the father in this case, and then give family leadership over to the mother. And so, that may involve, giving her consent rights to mental health treatment or something like that, so she can properly guide the family. So I'm not a real fan of this role, but of all your professionals, this is probably the least dangerous one, because the GAL, their obligation, now as I best understand it, is the best interests of the child. And so they have an obligation to the court to provide the court with accurate information about this. And so we can often work with the GAL to facilitate getting a proper assessment and an accurate diagnosis for the court. And I'm currently moving over or integrating AI into my consulting practice. And I think the AI will be have a positive effect on speaking with the GALs and helping the GALs get proper, develop a proper response to the family conflict. So the GALs are my least dangerous. Now, minors counsel is typically appointed for the child to represent the child's voice, and that is a highly problematic role. When we get minors counsel, we're essentially stopping everything. It's death now at that point in family. So if I've got a minors counsel involved, and the reason is the minors counsel represents the voice of the child, and they believe from their attorney perspective, the child says, I don't want to be with the mom. Now they have an obligation to represent the child's interests in that. That's not exactly accurate, okay, because minors counsels are not licensed by the state to diagnose pathology, and we're worried about a possible persecutory delusion with the father that's inducing a delusional thought disorder in the children. And if you simply express the voice of the child, you are expressing the delusional thought disorder. And in doing that, you are misleading the court around child abuse and around the child abuse of the father, because we don't have an accurate diagnosis. So my argument or statement to all legal professionals is you're not licensed to diagnose pathology. We're worried about a possible delusional disorder, possible child abuse by the targeted parent. The obligation of any involved legal professional, either your obligation to the court, your obligation to your client, your obligation to the child, is to ensure that an accurate diagnosis is made and that we get an effective treatment plan. It's to ensure that the court gets an accurate diagnosis for its decision making. It's not for the legal professional to make the diagnosis. Now, the legal professional is appointed to, minors counsel to represent his children, and certainly you want to advocate for their well-being. So let's get an accurate diagnosis so we know which parent's abusing the child, and then we can get appropriate advocacy for your client children. But as it currently stands, essentially when you appoint a minors counsel, you're appointing a legal representation for the pathology. The pathology is a shared delusion, so it's a factitious disorder, so it's going to be saying false things. And that's the whole entire nature. It's like a little ventriloquist puppet. You got the puppet, and it's being controlled in this case by the dad. So what a minors counsel does is then you're appointing an attorney for the puppet who's being controlled by the dad. So now dad gets two attorneys, one of which looks like it's representing the child, but it's not. It's representing the dad's manipulated voice. So you have two attorneys, one representing the dad, one representing the pathology. That's because that's what it is, the false words coming out of the mouth are delusion. So how we have so if you're going to, and mom only has one attorney, it's 2 against 1. It's not fair. So if you're going to appoint a minors counsel, what I recommend you do is you appoint another therapist for the therapy, for the healing, for the healthy side. So now you have an attorney for the mom, attorney for the dad, an attorney for the pathology, and an attorney for the treatment. That's insane. You have 4 attorneys, and it's like, no. My recommendation is if somebody wants to appoint an attorney on this, you appoint an amicus attorney. The attorney in Texas brought this up to me once as a role. I think that's an excellent role. It's an attorney representing the interests of the court, ensuring the child's treatment. And so that's a proper, appointing attorneys for children over empowers them, especially in an inverted hierarchy, family. So it's absolutely, from a treatment perspective, this is absolutely the worst thing you can do from treatment. And it's dangerous. So I don't recommend minors counsel. Amicus attorney, if you want that role. Move to a guardian ad litem if you want somebody in there that's more balanced on something like that. But ultimately, I don't think you need any of it. You need a family therapist. You need treatment and diagnosis to fix things. So this reiterates what I was just saying, which is the role of a legal professional representing the child is first to ensure that the child has an accurate diagnosis and effective treatment plan to fix things, to ensure your client gets good information and gets effective treatment. And second, to ensure that the court that the child has an accurate diagnosis for the court's decision making surrounding the child. And that's important. You're working for the court's interests here. And so let's get an accurate diagnosis for the court's decision making. So the role of the legal professional is not to make the diagnosis. It is to ensure that the mental health care system, returns an accurate diagnosis for their client that results in an effective treatment plan. So now, in addition to the various roles that can kind of get associated with this family conflict, and the reason we get so many roles is because the mental health system is failing. We need a diagnosis and a treatment plan. That's pretty much one therapist, okay, family therapist. We may add a little bit more consultants or something, but pretty much we just need one person. And the layers are a symptom feature of the failed forensic custody evaluation approach. So if we change the approach, we're going to reduce the need for all these additional professionals, one of which is this parenting coordinator role. That is an extremely problematic role relative to the Belmont report and impaired autonomy and decision-making of the parents and stuff. But this is directly related to the failure of the forensic psychologist, because they don't diagnose or treat. They come in with their custody evaluation, so nothing gets solved, and then they don't know what to do about it because they're not diagnosing or treating it. And so they're looking for legal solutions. So and the court's getting frustrated because nothing's changing. It's been years and there's been no effect. So what the forensic psychologists say is, well, they're fighting because they're fighting. So let's put in somebody to just make their decisions for them. That is so legally problematic. You haven't taken away their competence, so like they're not an old person and you're appointing a conservator for them. They're totally capable of making decisions for themselves. And we don't have child abuse, at least not diagnosed, so we have no reason to, overturn the parents' rights or cultural rights, personal. So if they're having conflict, well, people have rights, and one person may be right and one person and if you appoint a low-level professional, like a parenting coordinator, you're sending them into the most manipulative people on the planet, narcissistic, borderline, and dark personalities, and you're sending this little immature professional in to make decisions. They're going to be so manipulated by this narcissistic, which now they are a decision maker deciding in favor of the abusive parent and against the normal range parent because they've misdiagnosed the pathology. So if we're going to do a parenting coordinator role, and I recommend we don't, very much recommend we don't, but if we're going to do that role, we need to get them the support of the professional level diagnosis from the psychologist. So if a psychologist says you're a decision maker, and oh, by the way, dad is delusional and mom's a normal range parent, then that would be the guidance that they need for that decision-making role. But if we just send them into the most manipulative humans on the planet, no, borderline narcissists and dark personalities who are abusing the child, that's a recipe for disaster. And you give them powers that are just violating human rights and stuff. So I'm really worried. And so that's why I say it's a problematic role. We should just get rid of it. If you want to do something with them, you do the contingent visitation schedule. So now we have the reunification therapist as another involved professional. What strikes me about these families is everybody believes that the targeted parent is this font of money, and they begin putting all these people on their payroll. Holy cow, we need to be reducing the financial costs, not putting more and more of these people on the payroll. This is the only role we need. And I change it from reunification to a family therapist. Reunification is in foster care when you're reunifying with an abusive parent. That's not what's happening here. We are doing attachment therapy, recovering the child's healthy development. So let me just say something about that, because I've worked child abuse in foster care. So when the CPS removes a kid and places them in foster care, sends them over to our clinic, I've got a foster parent involved. The abusive parent is also sent to our clinic collaterally. And we begin the process of two things. One is restoring the child's healthy development while they're with the foster parent. So we'll be doing therapy, play therapy, or something with the child. In addition, we may be doing reunification therapy with the abusive parent. And so it might be a physically abusive parent. We, get them into therapy, get some feedback on that, and then restore the child's bond with the abusive parent with enough safeguards in place to make sure the abuse doesn't resume. They need to reassure us that everything's fine. Or the alcoholic parent, the neglectful parent, gets clean and sober, and maybe some supervised visitation for a while. All of that is reunification therapy with the abusive parent. What we're doing with the child is attachment therapy or trauma therapy or something over there. So what's happening in this family is actually the attachment therapy or the trauma therapy. It's not the reunification therapy with the father, who's the abusive parent. And so that would be a different component. So just to clarify the terminology related to things, I would prefer we use family therapy for this role rather than reunification therapist. And it also separates some from that parental alienation thing that was a highly problematic construct. So, but with the reunification therapist role, they have what's called duty of care, which means you're their patient. So it's their obligation, of all the mental health professionals, it is most directly their obligation to make an accurate diagnosis and develop a effective treatment plan. So when we look at all your professionals around you, this is the professional we want to focus on to get an accurate diagnosis. Now, if they're not up to the task, we get consultants in or we get them consulting with something, because we need an accurate diagnosis 100% of the time. Whether it's cancer or diabetes, I need to know how I'm going to treat it. And so this is the person that's responsible for that. Let me say something else about that. My role in the family courts to a degree is to get an accurate diagnosis, facilitate that on this initial encounter of the therapist with pathology, to assist them in getting that diagnosis that we can then move into treatment. If we're treating cancer with insulin, the patient's going to die. So this therapist is going to need an accurate diagnosis, because if they don't have it, the therapy's not going to work. We're treating cancer with insulin. And so that's an important feature for them. So that early consultation or that early diagnostic model is vital to this parent or this therapist being able to do their role. In addition, now we also have the various child therapists that get assigned. So in this family, each child might get assigned an individual therapist. That is going to be highly problematic, because if we have a shared persecutory delusion, these individual therapists from their role are going to believe the shared delusion, because what they believe they're doing is validating the child's feelings. And if you're validating a delusion, then you're helping to create the delusion. You're giving social support to the delusion that it's real. So it is vitally important that the child therapist get an accurate diagnosis, hopefully from the family therapist, that the child and the father have a persecutory delusion. So when the child comes in and starts talking about you, you can begin to treat the delusional disorder rather than facilitate the development of the delusional disorder. So competence is just phenomenally important, because otherwise the mental health people begin to become child abusers. They begin to participate in the child abusers because of their incompetence. They get captivated in this one, the protective other role. Holy cow, is the child therapist vulnerable to be captivated on their countertransference of the protective other in this. That's why they're child therapists, because they like doing children, and they're not in contact with the parents to give the additional information that this is a delusional disorder. Now, they should recognize that. They should recognize that the pathology in the family courts is a possible persecutory delusion shared and a possible factitious disorder imposed on the child, a false attachment pathology. That would be just baseline competence to know what the pathology is you're entering. And if they did that, then they could take the cautionary steps. But right now, that information is being withheld from them. And so we have people practicing beyond the boundaries of competence. And the individual child therapists are very much practicing beyond the boundaries of competence in multiple areas, but particularly the diagnostic assessment of delusional thought disorders. They're just not competent. That's what the pathology is. So they're practicing beyond the boundaries of competence, and are highly vulnerable to sanctions as a result. And then I just want to add, one of the other variants of this is sometimes we get extended family, like a grandparent or something, who also, or a teacher or something like that, who also gets into that protective other role of involvement with the family. So how do we respond, though, to this protective other who's in the situation? What we're looking to do, what my recommendation is cooperative assertion. Because they have power over you, you do not want to actively challenge what they do, because they have power and they can get vengeful and retaliatory. So you have to be kind of strategic and a little safety oriented relative to them and their power. At the same time, you want to assert that what you want is a DSM-5 diagnosis. You want an accurate and stay located in the DSM-5, because then you're grounded in healthcare. And so you have all the healthcare stuff and argument. I'm worried about diabetes or cancer. Can we get a differential diagnosis for diabetes and cancer? And then you just switch in, that they're abusive or I'm abusive, or they got the delusion and I'm abusive somehow. So you just switch in the differential diagnosis on that, cancer or diabetes, and just be assertive in getting that. And so the considerations relative to working with these professionals is that the professional may be in collusion with the child abuse, which is very concerning. So, and the professional may be in collusion with the spousal abuse, because they're not even recognizing the spousal abuse component. Let me say something about that. It's very interesting what the professionals believe their role is. However, all mental health professionals have duty to protect obligations for 3 dangerous pathologies: suicide, homicide, and abuse. And when we come in and encounter a dangerous pathology, our treatment roles or roles in the school or whatever become secondary features. We've encountered a dangerous pathology: suicide, homicide, or abuse, child abuse, spousal abuse, or elder abuse. All of a sudden, our duty to protect obligations are active, and we have to do certain things. Okay, because now we're dealing with a danger. I don't care what you think your role is. If the person says, I'm going to jump off a building and kill myself, okay, hold on a second. I got to respond to your suicidality. I have to respond to the child abuse. And in this case, we have 2 potential abuse pathologies with 2 separate individuals. One is the child psychological abuse with the child. The other is a spousal psychological emotional abuse of the targeted parent. So we have 2 duty to protect obligations. Now, if we solve the child abuse component, we will also solve the spousal abuse component. That's why we focus on the child abuse. but we have to acknowledge and recognize that we have two potential abuse diagnoses. And that becomes important because when the professional becomes a collusive participant in the abuse because they believe the shared delusion, then they are not only contributing to the child's psychological abuse, they are an active spousal abuser of the targeted parent. And so, as the role responsibilities of these professionals need to comprehend both sides of that duty to protect, because we have a vulnerable parent subject to the court. The parent and the child are required to accept whatever quality of mental health services they're given. And so if they're given awful mental health services, we're basically participating in their psychological abuse, court-ordered psychological abuse. So the mental health people involved in the courts need to be very, very cautious about the coercive nature of the courts and about our responsibilities relative to dangerous pathologies, suicide, homicide, and abuse. So then the other consideration is in all of these cases, whether the professional is a legal professional, GAL or minors counsel, or whether they are a mental health professional, individual therapist, family therapist. The goal all the time is to get an accurate diagnosis for our decision making. And a diagnosis means the same thing as identify. We want to identify the cause of the problem so we know what to do to fix it. And so that's always the goal. When I'm brought into a matter as a consultant, my first question is there any current mental health or is there any mental health involvement? And if I'm told yes, my next question is, what's the DSM-5 diagnosis? I want to know what's going on, and do they see the proper diagnosis? And oftentimes, pretty regularly, I'm told there is none. Well, then we need to get a diagnosis. And if there is no mental health involvement, then we need to get a diagnosis. And so that always guides things. What's the diagnosis? Then we'll know how to treat it. ADHD, autism, trauma, child abuse, delusional thought disorders, factitious disorders. What's the diagnosis we're treating? So then, as a parent interacting with these professionals, you want to manage your emotional signaling. So you don't want to be assertive. And if you're assertive, you're in a background state of angry, like I am right now. So I'm asserting things. I'm trying to convince this professional that they need to be diagnosing it. It's the father that's doing this. And the moment I'm in this background emotional signaling, the other recipient is going to go, don't tell me what to do. I'll decide on myself. And so you get a defensive response. And that has to do with the background of angry, power assertion in voice. What it generates angry in response. What we want to do, or what I recommend you do, is you switch emotional signaling over to the happy channel. And look, I can do that so easy. I just smile and I get a little low to my voice. Now, if I just keep a little smile on or keep it oriented in this happy tone, and you can hear the change in my voice, now I can be assertive and talk about how the dad is actually creating this pathology. And he's the one that's manipulating the child. But you notice the difference in tone, the emotional tone, when I'm saying the same things. And what you're doing is you're adding the emotional tone of happy, which is social bonding, and you're adding the social bonding layer to the assertion layer so that the recipient will be responding to the emotional tone, the emotional signaling of social bonding, and then they will be less resistant to the assertive information you're providing. So that's just a little thing about when you're working with the professionals. I wish you didn't have to do this. I wish they were smarter and could figure things out on their own. But until you get out of dangerous situations where you're having to not be necessarily assertive and you need to kind of watch out for the dangers that their power holds for you, you want to manage your emotional signaling to get the social bonding. And then finally, I would recommend that you give your professionals the problem to solve. And so if you're the only one carrying the motivation to solve this and everybody else going, well, I don't know, we can leave it the same, then you're going to get really frustrated. Okay. Especially in the role, these people have roles to fix things. And that's treatment means the same thing as fix things. So if you stay on the word fix things, you want them to, it is their job to fix things, whether it's the attorney or the, therapist role or something, fix it. But you don't want to go fix it because that's angry. So you go fix it. Or you move the sad emotional tone, which is draws nurture. So when you're talking about the difficulties in your family, give them the sad tone about how it's devastating you that will draw their response to nurture your sadness. And then you give them the problem. That's their job to fix it. I can tell you how to fix it because I'm the parent. I know it's him causing it. So we need. So what are you going to do? How are you going to fix it? This is not getting fixed. And what are you going to? And so by moving with that fix it communication and giving them the responsibility to do it, not taking it on, it's their obligation to make things happen. And then the second line where you're giving them, I want a diagnosis so we can come up with a treatment plan to fix it. You're giving them a rational and reasonable step forward, and that's what the court should want. The court wants it fixed. The court going to need a diagnosis, and so it all makes sense. And that's how you challenge the irrationality of a delusional thought disorder. It's a thought disorder that we're working with, and so it's not going to make sense because it's thought disorder. So what we need to do is come back to stuff that's relatively simple. Diagnosis guides treatment. We need a diagnosis, and that makes sense. We need a diagnosis to come up with a treatment plan. We need a treatment plan to fix it. I don't care what the custody schedule is. We need to fix it. We need to land on a healthcare solution of treatment, not a legal solution of custody. So returning again to this particular family, just to look at it, we need to obtain an accurate diagnosis from healthcare. That's the fundamental feature when we get on. So pretty simple. Now, in this situation, we need to manage the spousal abuse. Now, here's the situation with this one. This situation is the minors counsel is going to be totally sided with the pathological parent and the child abuse because they're representing the ventriloquist puppet. So they will use their authority, which is often considerable with the court, to completely enact the pathology, which means the spousal abuse component is going to go off the charts. And so we're going to have in this case, I've got a spousal abuse mother who in this situation is just off the charts. Okay. So the grief response is going to be substantial. And the trauma response is going to be substantial. So as a mental health professional involved in this situation, my first consideration is to getting some treatment support into the spousal abuse victim in this situation. The other feature about this for many of you parents out there right now is if this situation gets extremely intense where there's just no solution to this and you're a spousal abuse victim and they've got your child and they're abusing your child and you can't stop them, one of the issues about managing that spousal abuse is to disconnect your motivations from the situation. You kind of have to give up. And for your own sake, because you're active spousal abuse, you can't do anything about it. So they're coming over. So you have to leave that situation emotionally, psychologically. So you basically give up, but then you don't actually give up. Okay, we never do that. So we have the situation. So we would continue to activate resources into that. I would suggest AI consultation, get my information into them. We can figure things out about how to get neutral information into the minors counsel, into the court, into the situation, maybe get minors counsel off, get over to guardian ad litem or something, but we'll continue to work on the situation. It's just for the interim where you have no power and they're abusing you to such a significant degree, then we need to consider how to protect you emotionally and psychologically as an abuse victim. That's why recognizing two abuses becomes a relevant consideration on treatment when we have this kind of situation. Now, we don't ever stop, but we do want to recognize the validity of the fact that you have no power, okay, and you're just getting dominated and abused, and your child's getting dominated and abused. So, so the role of the parenting coordinator, that I would just eliminate the role if I had my choice. But if you're going to keep the role, then I'd shift it over to managing a contingent visitation schedule. So let me see, yeah. And then for the reunification therapist, that you want an accurate diagnosis from this particular mental health person. And something important to understand with this person, with all of them, is the patient should not need to educate the doctor. That's not your job to educate the doctor. It's their job to already know. And if somebody's going to educate them, it should be another doctor. So you can get them over to all my information on YouTubes and stuff, and we'll be trying to get them more information. Using AI again to educate your doctor is useful because AI is neutral. And so if you ask the proper series of questions through, and you can do that over and over in your privacy of your own home, asking questions, framing up the information, and then present that. And you can actually take their response and put it through AI and see if it's responding. And so AI is going to change a lot of how we do oversight and diagnosis and treatment in the family courts. So that's an opportunity we have moving forward. So then for the child therapist, when you're in this situation, the goal is to transfer care over to a family therapist. We don't need child therapists. Let me say something about that. I've worked with children. I'm a child and family therapist. We don't need child therapists for this, okay? The children are okay. The children are normal and healthy. The problem is not the children. The problem is the parents and the family context around the children. If we fix the parents and the family context, the children's lives will be okay. We don't need individual therapy for the child. And so let's get a proper structure to our treatment to fix it. Otherwise, we're just adding people and adding confusion and stuff. Now, if you want a child therapist for something like an eating disorder, and the family therapist isn't competent on an eating disorder, they're treating the oppositional defiant or something going on elsewhere, then you go out and get an eating disorder team, a dietitian, eating disorder, but that's a collateral and it's specifically focused for a specific thing. If you got a child with a phobic anxiety and you're treating some family dynamics, you may get an anxiety therapist to focus on desensitization or exposure or something like that. But you bring an individual therapist on a specific diagnosis and you get a good treatment plan on that. Mostly we're going to want to run through the family therapist. And so one of the issues when you have that is transferred over to family therapy. These are superfluous people and at high risk for becoming participants in the child abuse if they don't understand it. So if you're going to put a child therapist on it, they have to be familiar with court-involved therapy and narcissistic and borderline and attachment pathology and how to fix attachment pathology and delusional thought disorder. They gotta have background competence in that because it's a very dangerous role if they're not competent. And so now taking a look again at the family, coming back to the family structure without any of the professionals and just touching base on what we're looking at here. So first, we're looking at a narcissistic dad pattern. So we're going to have a higher spousal abuse feel to it. If we had the lied mother in this situation, we'd be looking at a borderline mom pattern. It's going to have higher false allegations and higher anxiety. So here we're worried, just because I'm looking at this diagram, I'm worried about spousal abuse. So the mother using the children as a weapon. That's just on my differential diagnosis here, recognizing I have two now duty to protect obligations potentially active. In addition, we've got the oldest child is a girl. So we're into that psychological incest pattern. A special relationship between the father and the daughter that excludes their mother. That's going to be devastating psychologically to that girl. She's replaced the mother in her father's special role affections, and that's just, we need to get her out of that. Now, because she is on the cross-gender high affection bond with the father, he's going to be able to manipulate her using his attention and his affection and the withdrawal of that. So it's very powerful, the old he has. And because he's a narcissistic dad, he has no love inside. So she's going to be very, very vulnerable to his use of his charm and his psychopathic, narcissistic kind of expansive mood. And she's going to be very vulnerable to manipulation from that and to this groomed and seduced basically by her father psychologically. I'm not worried about actual sexual abuse. I'm worried about this, the ripple of it. But he's going to groom and seduce her into a special relationship that excludes the mother. So that's that aspect of the pattern. Now, in addition, we have a younger son on the other side. He's on the same gender bond with the father. He's going to escape early distortions, but he will be brought in once Naomi and her father are kind of stable in their relationship. The splitting polarization of the father is going to force him to also join that little collective and rejecting the mother. In addition, though, something to recognize at 11 years old, he's going to have a long-term movement into this. Now, Naomi's going to hit 14 and 15, and so she's moving up into a more adult to adult kind of role. But Tyler here is going to be involved in this family for quite a few years yet. So it's incredibly important that we fix this family right away so where we can give Tyler a normal arranged childhood and we don't spend 2 years, 3 years, 4 years in a custody conflict that destroys that aspect of his life. So we got let's get on this quickly and solve it. In addition, let's get Naomi out of that special relationship with her dad, get balancing influence of mom back into that role relatively quickly. We love high affection coming on the cross-gender father-daughter bond. Yay, I love high affection coming from dads to their daughters. I just want the balancing influence of the mother-daughter bond in there. If I don't have that mother-daughter bond in there, then I need to turn down the father affection because I'm on a creepy kind of line there or pattern. So that's Tyler in this. The other feature about Tyler, just looking at this, he's a son on the cross-gender high affection bond with his mother. So one of the features I want to absolutely protect in therapy is that I want Tyler to always feel abundant love from his mother. And I want Naomi to feel that too, just as a child. But particularly on the high affection bond, I want Tyler to feel loved by his mom. And in this rejection kind of stuff, that's devastating. Yeah, it's going to create mommy issues for him forever if we don't have a healthy mother-son bond. And then finally, the issues with the targeted mom, the spousal abuse issues are considerable. And let me say something about that as well, because in this pattern, I'm going to have a spousal abuse victim in the mom. So she's in a traumatized brain. So as I'm encountering her and working with her, I have to understand that. So a lot of times in my consults, I'm downloading in, we need to do this and we need to do that, and giving her all sorts of information, plans and stuff. But I have to recognize then that she's got a traumatized brain and she has to go out and actualize all of that. So we need to get some support into her. So it's either therapy support, her own individual therapy, or a coach. This is a good one for an experienced family coach in the court system who can get that additional support and carry a lot of the background information. So I say something once and then the coach can continue to elaborate on that and help her actualize things. Coaching for the father is the same thing. It's the father's in the spousal abuse role. It's a little bit different. For the father, his grief is going to be off the chart. For the mother, she's going to be more trauma impacted. So it's a little bit variant on the both, but both of them are spousal abuse victims, very, very much so. There's nothing like losing your child. That is significantly problematic. So with all of these cases, I recommend we get an outcome measure. So I would want, with this family, I'd want mom in this case to rate the child's symptoms on affection, cooperation, social involvement, a 1 to 7 scale, send them over to the family therapist every day. And we want the child to be 3 or higher, so that we just want normal range from the child. We use that to communicate to the children that this is our expectation. We use it in family therapy to talk about what is normal and what the ratings are and give them a reality-based understanding of relationships. And it also takes the focus off, therapy focus off talking about past unsolvable events to current situations and current relationships. We're going to stay focused currently. So an outcome measure is very, very, very critically important on this pathology, all pathology. Treating depression, you want to find, give me on 1 to 10 scale, how bad is your depression this last week? So we always want that kind of more precise symptom information coming in to guide our decision making. So always get an outcome measure on this. And with that, I'm going to wrap up my vignette for the Miller family regarding the surrounding professionals. And so you can see, you just take your narcissistic pattern, your borderline pattern, then you add, new spouses and step parents or grandparents or extended family or professionals, and you begin to elaborate on basically two patterns. Now, can those patterns switch? Yes, you can have a borderline dad and a narcissistic mom, and those have particular variants to them. But we start basically into the two patterns, and then we can do the various variants off of that. So with that, I'm going to head off to my day, and good luck to everybody in getting an accurate diagnosis and an effective treatment plan. We always land on treatment. So with that, bye-bye.